Today, the Committee on Health, Tourism, Historic Preservation, Land and Justice is now called to order. Today's Monday, November 30, 2020. The time is 2:01 p.m. Notices for this public hearing, it's an oversight hearing, were disseminated via email to all senators and all main media broadcasting outlets on Friday, November 20, 2020, and again on Friday, November 27th. The notice was also published in the Guam Daily Post on Friday, November 20 and Friday, November 27, 2020. This Zoom meeting is hosted by the Guam Legislature's MIS and my staff, and they will mute all Zoom participants until called upon by the chair. Individuals testifying shall first be recognized by the chair before speaking and begin by stating their name for the record. When called to speak, of course, please make sure you are unmuted. All right, I'd like to thank my colleagues for being here, beginning with the Legislative Secretary, Senator Amanda Shelton, Senator Terlaje, thank you for being here. All right, I of course want to also thank the Department of Public Health and Social Services, as this is an oversight on the Department of Public Health and Social Services on certain topics. Prior to the start of this hearing, those testifying today were sworn in by the Guam Legislature Sergeant at Arms. Thank you, Sergeant at Arms, and thank you to those who were sworn in. So we will be conducting an oversight hearing to discuss some of the overall strategies and plans recently reported in the media that the department will be implementing to contain the spread of COVID-19 and the data that is used to make these decisions and plans. This is the fourth legislative hearing held by this committee to receive updates from the Department of Public Health and Social Services on their efforts during the public health emergency. The first hearing was held on May 8th, the second on September 10th, and the third on October 1st. Guam's ability to open businesses and schools and to coexist with the COVID virus while protecting our large population with increased health risks depends squarely on Guam's ability to isolate and trace COVID-19 positive carriers. With each oversight hearing, we heard the progress the department has made in expanding its testing capacity and contact tracing. In May, the department had a testing capacity of only about 200 to 300 tests per day, and there were only about 6 contact tracers and 6 investigators on staff to conduct follow-up investigations and contact positive individuals. In October, the department and other labs and testing locations combined were testing on average about 600 to 700 per day, and were about 22 investigators and 28 contact tracers on staff to address the surge in positive cases at that time. We were told in May that it was taking the department 1 to 2 days to contact positive individuals and complete contact tracing. This, of course, was when our numbers were significantly lower than they are now. On October 1st, we were told that the department could contact a positive case, close contacts, plan isolation, and instruct on quarantine for family members within 5 to 8 hours of test results. However, since then, the island has seen a sustained and extended surge of positive cases through October and early November. I've heard from constituents that positive individuals and close contacts of positive individuals continue to wait several days before hearing from the department. Some have not heard at all. So while there have been improvements in our testing and tracing capabilities, we still need to know if the department has been able to increase its capacity to meet the steady surges in positive cases that we have seen in the last few months, and the capacity that we will need to move forward, of course, with opening more businesses. We need to know how timely they have been in conducting the tracing and the investigations. The committee's also been consistently pushing the department to provide more data regarding positive cases, clusters, and information that will assist the community in understanding how the virus is being spread and how the government is using this data to inform its decisions and strategies to combat the virus. In May, there was still little data provided to the community regarding positive cases. Since then, there have been daily situation reports with some general information regarding the spread of COVID-19 through community contact, household contact, workplace contact, and healthcare contact. It also mentions travel history of positive cases. There have been some reports from the department on various clusters. However, that type of reporting has been inconsistent. Sometimes establishments were named and other times they were not. The department told the committee in September and again in October that a more robust surveillance report with more data would be released on a weekly basis. After our October 1st hearing, the department shared more information regarding the ethnic and racial breakdown of positive cases and used this information to deploy the rapid engagement team to conduct targeted testing and outreach. More recently, a major cluster was announced in the construction industry, and it was private companies who shared their information regarding these positive cases at their particular company. We've yet to see more data from the department on positive cases in a systematic way where the community can understand where the positive cases are coming from, how much community spread is occurring, and if the spread is a result of non-conformance to guidelines by the businesses versus individuals' failures to wear a mask or otherwise follow guidance, or whether the spread is due to close contacts despite the masks, or some other risk factors that we can also share with the public. Since May, the committee also encouraged the department to request supplemental funding from the $118 million in COVID-19 relief funds administered by the administration. The department reported to the committee that they requested an additional $3 million because it only received about $500,000 from the COVID-19 relief funds, that $118 million pot. A portion was also budgeted for overtime pay of Department of Public Health and Social Services workers. The department reported that the $3 million supplemental funding was approved. It was unclear from the latest October 31st COVID-19 relief funds report submitted by the administration if that $3 million was budgeted or expended. This supplemental request was meant to be used for an additional 30 staff and also to provide for additional PPEs, supplies, and equipment, according to documents submitted to our committee from the DPHSS. The previous director informed the legislature since June that a portion of the $3 million would go to Environmental Health Division to assist its efforts. Committee is also aware of the direct federal grants the department has been utilizing for different program areas. In September, Public Health reported about $22 million in direct federal grants for COVID-19 related services and programs. For contact tracing, testing, and investigations, about $6.1 million was received from the Epidemiology and Lab Capacity, ELC grant, and $1.2 million from Community Health Clinic, CHC grant funding. Today's oversight hearing will focus on the department's one, timely release of data regarding positive COVID-19 cases to assist contact tracing efforts and prevent community spread, and two, an update on the contact tracing capacity. We've previously announced we would also talk about details of the enforcement of public health guidance, but since those rules have now been put in place, we'll talk just a little bit about that. So the intent of the hearing is to hear more from the department, just so that we can all continue to be on the same page regarding how to contain the virus. Our efforts can all be in sync, how to ensure that the data is shared with the community so that all will have a better understanding of the government's plan and strategy moving forward, and the data and information being used to support the rationale behind those plans. Also to see where there may still be gaps or needs for more resources or assistance. All right, so all right, before I go further, if I may recognize the presence of Senator James Moylan. Thank you, Senator, for being here. Senator Legislative Secretary Amanda Shelton and Senator Terlaje. And I know we are here with the department director, Mr. Arthur Augustine from DPHSS. Also deputy directors, Terry Uggan and Laurent Duenas. And I see Annette Uggan, who is the COVID-19 Epidemiology Surveillance Branch Lead. Dr. Suzanne Kaneshiro, who's the Public Health Officer, Division of Public Health. Dr. Ann Pobutsky, the Territory Epidemiologist. Mr. Chima Bakwem, Projects Coordinator, Office of Healthcare Associated Infections, Epidemiology at DPHSS Bureau of Communicable Disease Control. Anne Marie Santos, Guam Public Health Laboratory Administrator. Mary Lou Scroggs, Environmental Public Health Officer Administrator, oversees DPHSS COVID-19 inspection of governor's executive orders and public health guidance memoranda. Rosanna Rabago, Acting Chief Environmental Health Officer from the Division of Environmental Health. Masatomo Nadu, Chief Environmental Health Officer. He's been reassigned, sorry, that's not his correct title. He's now lead on the response, I think. All right, and I don't see some of these others who were listed, but okay. And Mr. Tommy Taitakui, DPHSS Administrative Services Officer. Is Grace Berdalio here? Okay, all right, so we'll proceed. And I sent some questions in advance just to give you an idea of what we were going to discuss today. And of course, my colleagues also have questions, so I'm just going to proceed with some of these questions to the director, and you may, of course, invite anyone else to also testify. But during this September 10th, we're going to talk now about the timely release of data regarding the COVID-19 cases to assist contact tracing efforts and prevent community spread. So during the September 10th hearing, the department reported it was in the process of streamlining the daily situation report and would be releasing a weekly surveillance report that provides more detailed info about community spread and positive cases. On October 1st, the department said they were still behind on data management and migration and reported that it will be at least another month until we get more robust weekly surveillance reports, which will break down community spread by activity categories. So I had asked, is the weekly report that was described there now available? What new detailed information will be released in the daily or weekly reports? The public's been clamoring for more data. Why is the department moving to weekly reports versus daily reports? And, will the daily reports be able to continue? How will the change to weekly reporting increase the public's understanding of where there are known COVID clusters and assist in slowing the spread of the virus? So if we could just talk about that weekly versus daily reporting and additional information that I know Dr. Babutsky, you've been working on this for a while.
Yes. Yes, this is Ann Pabutsky. I'm the territorial epidemiologist. The weekly report should be available. It should be out this week, maybe even today. Stephanie and Vince are working on it, and we just moved. We had a number of things happen in the meantime, and it should be out this week. And we're continuing to do a shortened daily summary each weekday that includes the basic information that was in the SITREP, including the case count, daily and weekly case count, the type of test done, new tests, percent positive, and the breakdown by the case status, such as deaths, active isolation, military and civilian, and then current isolation location. It's basically a daily summary, and that's been going out now for the past couple of weeks. The weekly report will include a lot more data on the characteristics of cases, including more detailed demographics, information on chronic diseases, hospitalizations, deaths, the response metrics, the at-risk groups, and vulnerable populations, and clusters. So that's supposed to come out on Mondays. The idea is we'll get the hospitalization data up through the week, and then we report that weekly on Monday, and then the daily summary will continue. That's the plan. And I can grab Stephanie to come on in here if you want more detail. She's actually working on it right now. She's trying to finish it today. We've actually had quite a bit of input on this report, starting with Stephanie and myself back in August when we first started talking about this. And then last month, the last 4 weeks or so, we had some help from the CDC. We had a deployment team out here, including a biostatistician who was helping us a little bit with the hospital data. And then we just hired a young man from the math department at UOG, and he's been assisting with compiling the data for this weekly report, as well as doing data entry we're still trying to get caught up. And in the middle of all this, we had a move. So we're now at the ITC building instead of down there at the RANCare with the lab.
All right. So you read a list. Sorry, I don't have that in front of me, but you read a list of items that will now be available in that weekly report.
Right.
Including, I think you said ethnicities and.
Well, ethnicity is always up there. It's on the dashboard. Ethnicity
too. Yeah. So what is, sorry, but can you just remind us again? What is new info that we've not seen before? Or is it just a population that's new?
On symptoms, the number of people with chronic diseases, some of the characteristics of the deaths, hospitalizations, clusters, some of our response metrics, and then at-risk groups and vulnerable populations.
Okay, great. Can you give me an example of how you were reporting at-risk groups? What does that mean?
Well, for example, Vince and Stephanie are compiling the weekly report, and I've been dealing with the death data since we finally have enough to kind of deal with deaths. There's more than 100 now, and we've been getting the death certificates. So we're able to basically triangulate the data from what we're getting on the report of a positive. So there's that data, then we get doctor's notes if they die, and then we also get the death certificate information. And from that information, we're actually able to get more of a picture of people at risk for death. And what we have found, I presented this to the Diabetes Coalition just last Saturday, the 14th, that more than half of our cases who have died have diagnosis of diabetes. And it's usually diabetes, hypertension, and or cardiovascular disease, which is much higher than what we see in the States. So that's something that that would be like a special report that we would add to the weekly surveillance report. I'm hoping to do this at least once a month just on the death. It just takes a while to compile that data. And it's mostly elderly, and we have seen some younger people die, but the vast majority of the deaths are elderly people who are at risk with these underlying conditions, mainly diabetes. So that's the kind of information we want to put into the weekly report. It's kind of a special section. In addition, we're going to look at the hospitalizations over time, of course, the case count, the stuff we all saw in the sit rep, but it'll be weekly. So it'll be more of a summary, and you'll still get the daily case count and the basic information so that we can have more time to do this kind of more detailed analysis to tell us what's going on. The idea is to have more actionable data. And I don't know if we're ever going to get there, because as we found out, the rapid response isn't really rapid. It's not like we have a SWAT team that goes out. It just takes time to delve into the information that we receive, sort through it, and try and figure out where things are happening. Except for these recent clusters. The clusters are we've done a bang-up job on those construction sites because we were immediately able to do a rapid response for that. So I think the department's very capable of doing that more. We don't, of course, want to see any more giant clusters like that, but hopefully the data that we're compiling will give us a little more information. We do know it's community spread. We're not seeing travelers like we did in July who are being caught in quarantine. We are seeing community and household spread. It's mainly household spread. And there's not a lot you can do about that when you have multi-generational families, or you have just overcrowded living conditions where people can't social distance. So we hope to be getting this information soon. Hopefully, if you want, I'll go grab Stephanie and she can give you an update if you'd like that.
All right. Well, we can read the reports, I guess. So we just want to make sure that these are actually coming out and what will be in them and why. So if I could also ask, then what do you mean by the your matrix, your response matrix? You said that would be included in the report also.
That's something else Stephanie is compiling based on. Those are the performance indicators that the MDs are requesting. Why aren't people responding to the calls? How much time does it take? And to contact someone once they're a positive.
Oh, okay. Okay, great. So, that might answer some of my questions too. Okay, so what about, will you continue to report on the epidemiological data such as spread through workplace, household, community?
Yes, everything that's in the surveillance report will be there, but there's going to be some additional information on the chronic diseases, deaths, hospitalizations, clusters. So and because it's more information, it's just going to take a little longer to compile, and the report will be a little bit longer.
All right, but I'm with you on actionable data, so it's got to be in time that we can act on it. But what about when you say clusters, do you mean workplaces, or will there be more detail on what community contact means or something like that?
Well, yes, and it'll be detailed to the point where we can say, here's the type of cluster. We're not gonna, I don't know if there's any plan to release names of places as opposed to saying, here's these household clusters, here's these mass gathering clusters, here's a church cluster, here's a work site cluster. We're still working on that. And actually, Stephanie could tell you more. If you want, I'll go grab her.
Can I ask you one more question? If there, are you able to tell from your data that whether, for example, the clusters are relevant for me? For example, if it's a church cluster, I want to know, is it because this church is not following the guidelines? Are you able to determine those types of, that type of information? Because, you know, we might end up closing all churches saying they're all high risk when really it's really just a couple because they're doing something different or they're doing certain behavior that needs to be modified.
I'm not sure. Again, that's a stuff that would be also for the contact tracers. The question about what kind of data we're planning to release in terms of details. Obviously, if we keep seeing church clusters, we are seeing workplace clusters. There's some persistent cases that we keep getting from certain places, DOE, you know, we get cases that crop up, the Port Authority, et cetera. But if there is, I'm sure if we did see significant church clusters, we would be able to red flag that, just like this construction company where the contact tracing people were able to red flag what was going on there, saying, whoa, we got this many cases. And then, and you know, make sure that we move on it.
Okay, can you tell me why you are not going to be reporting names of establishments?
That's an Annette question. Or that might be a director question. I don't know. You know, some states, like when we were looking at our weekly report when we were looking at examples from other states, we looked at Oregon, and every week they would actually list all of the nursing homes that had significant numbers of cases, but they had 400 nursing homes listed in the back of their report, 5 or 6 pages. We just don't have those numbers to justify doing that on a county level. We don't have counties. So because it's a small island, I think that's part of the consideration. And then I believe we were talking about a policy about this, and Annette and the director can maybe speak more on that.
All right, Director or Annette.
Madam Chair, it is my understanding that we are seeking an actual AG opinion. Prior to that, we had sought just guidance from the AG where we couldn't release what that opinion was. But also there was additional information provided by the CDC deployment team when they arrived, and from CDC in general, that we have to weigh the pros and cons of outing people, outing businesses, because then that actually might have a negative effect where future businesses will not want to cooperate with us. And so again, I know we are seeking an actual formal AG's opinion, ma'am.
This is Arthur. Good afternoon, Madam Chair, Senator, and Senator Shelton, Legislative Secretary, Senator Moylan, and Senator Terlaje. Just to add on to Annette's comment, she's on spot. We have been reconsidering, actually seeking a formal opinion, simply because also more recently with the CDC deployment team, they did express concern, and is there really a need to disclose the identity of establishments when there's also the concern of potential liability to the department. So we want to really take all this to the AG's level now and have them give us an opinion whether it's pretty much in line with the guidance, only if it's related to a public health function like case investigation. As you had said, Madam Chair, with the situation in the construction industry, which was brought up just a few minutes ago, I believe you perhaps were all aware that they stepped forward and they identified themselves, and we had a really good relationship with them in terms of the work that needed to be done for testing and retesting, surveillance and monitoring. And it's pretty much almost a day-to-day touching follow-up with them in terms of where the workers are at, making sure that those that are negative and perhaps are starting to display symptoms were tested, and if they become positive, we would then restart the last day of exposure to those that were not positive. So there's been a lot of cooperation from the two key construction companies that identified themselves earlier. But we are looking, Annette is right, we are probably going to, as I have stated before, look for, seek an opinion. And so that we would be guided by that opinion for future situations that may erupt or come forth that we need to identify the establishment. So that's where we're at on that, Madam Chair.
Yeah, if I could just follow up. And you said that the fear is that in the future, establishments would not be willing to cooperate because their names would be in the paper. But right now, you receive information of every positive case, and you are able to determine where each of these people work, right? Or where they have been active, I guess, right?
Based on the interview and if they're willing and upfront with giving it to the investigator. Yes, Madam Chair.
Okay. All right. Yeah, I guess I'm thinking, yeah, you're going to get that information regardless of whether their bosses want to be cooperative or not, because it's the employees or, the individuals that you are in contact with. But okay, we'll hopefully see this AG opinion. I'm going to ask a couple more questions, and I'm going to open up this part just for my colleagues. So what data from public health is the governor and the physicians advisory group using to make its recommendations and decisions regarding strategies or rapid engagement recommendations, industry closures, extending stay-at-home directives? Is there any other set of data that we are not talking about here that they are privy to, or is this the same data?
The data that we're sharing, Madam Chair, it's hospitalization, deaths, positive cases, tests conducted. So it's pretty much the data that we are looking at. The CAR score, which Dr. Cabrera puts forth, as we provide him tests from the different labs, how many are positive, negative, how many have been hospitalized, how many on ventilators. And so that's the data that they're looking at. Deputy directors, of course, you're free to please share if there's additional data there that I may have not added on that is discussed during the meetings with the governor and the team. Also, in terms of the rapid engagement team, we look to our epi, Dr. Ann, for data that she presents to us that would give us indicators that there is potential cluster or concern, like we did up north.
Right. I'm asking, is it the same information that is going to be released to the public on a weekly basis that they are getting, or are they getting the additional information? For example, instead of churches, are they being told which churches or what activities?
No. I sit at that meeting almost 99%. Once in a while, I'm not able to join because of a conflicting schedule. But if I'm not there, Deputy Duenas or Deputy Uggan are there. And unless they've disclosed anything else, no, we do not disclose. Unless the company has come forth, like with the construction company, they came forth, so of course that information was shared. Whatever the public is getting that's disclosed, we are sharing with them. There is no additional data that I can think of that we share with that team that's not shared with everyone else. Unless Lori or deputies, do you have anything else?
You're spot on.
So Dr. Ann, I know you said, if all things go well, are you saying that it's possible that we might not be getting the data regularly? Or
Dr. Cabrera, he gets a little more detailed information from the hospitals that he posts in the physicians advisory group chat. For example, the number on ventilators. I believe the surgeon's cell and maybe it's the National Guard or Homeland Security also gets that information, but it's provided to those physicians as well as the sit rep. And so it's a combination of data that they're getting from public health as well as the hospitals. And then the CAR score is something he creates. A COVID risk score. I think it was originally designed to see if they could open up tourism and the schools, that sort of thing. And it's just been evolved into a metric that he really likes. And I guess the physicians advisory group likes it as well.
All right. Well, I want to know, at least me, I'm pretty sure I speak for some in the public that, we want to know what it's based on. Yeah. So all the info that is available, how they are, so we can help understand how everyone's coming to these decisions, for example, to extend the emergencies. Okay. So on this topic, just the data and the new reporting, are there any questions from my colleague, Senator Shelton?
Thank you very much, Madam Chair, and thank you everyone at Public Health, Mr. Director, the deputies, and everyone on the team for being here and taking time. I know how busy you all are, and we appreciate the information that you're sharing with us and sharing with the public at home. So thank you very much for all the work that you're doing. I was wondering if you could provide us with an update about the COVID-19 app and the data that you
sorry.
have from that.
Yeah, we're gonna get to those, I guess, on our contact tracing.
Yeah. Okay. I'll wait then.
Their reports, data reporting, increased data, or if there's any other parts of the data that you want to talk about.
Sure. I'm okay right now then, Madam Chair.
Okay.
Thank you very much.
Senator Titlegy.
No, thank you, Madam Chair, and thank you everyone for being here this afternoon. Thank you. Senator
Moylan. Okay, thanks. All right, so we'll move on. And of course, I'm still pushing for more data. I've been receiving reports from employees who are told that they're not told by their employers when the business has had COVID cases, and they believe that they've been exposed. But I just, no way for us to verify this information without knowing. And I just think it would help. All right, so, all right, we're going to move on to the contact tracing capacity. So during the October 1st oversight, you reported 22 investigators, 28 contact tracers. Also assisting were 42 DOE nurses, 38 public health staff, among others. In addition, you had public and private partners who had been trained, and a pilot project at UOG was going to begin that week to augment the investigation team at a separate site. If you could please provide an update on the total number of investigators and contact tracers on staff at the department and other public and private partners. How many additional have been hired since October 1st or are in the process of being hired? And are the additional positions being paid for with local or federal funds? Are there plans to bring on more staff to handle the surge of cases going forward? And I also asked that you, sorry, let me just stop there. Yeah, we'll just, Director, or who would like to answer?
Thank you, Madam Chair. This is Annette again. I'm the EpiServe Surveillance Branch Lead for the department's COVID response. In regards to the number of investigators, ma'am, our department currently has 21, plus one new one that was just hired last week. So that brings it still to 22. For our contact tracers within the department, to include our Department of Labor participants, we have 35. And then for the University of Guam, the extended program over there, we have 26. In regards to additional partners in our community, we still have our GMH and the Port Authority, GPA, and DOE, as you mentioned, ma'am. However, we now have Catholic schools. We have 3 staff there designated to assist with contact tracing and communication with the public health team. And then for the transportation company, Ambith, we have 1 individual there, as well as Payless Supermarkets. Overall, for all branches, we have 1 individual who coordinates and communicates with public health staff. In regards to additional staff brought on board since October 1st, there was the one I mentioned earlier, which is through the ELC COVID funding, and that's a CDC investigator. We actually have 3 additional staff funded through the ELC COVID grant that will be starting this upcoming Monday, December 7th. There are 9 positions under the ELC COVID grant funding that are in the process of being hired. So their dates, start dates are still to be determined, ma'am, but that's a 9 more. In addition, through the CDC Foundation, their federal funding, we have hired 3 individuals to help with case investigation, contact tracing, and we have an overall response coordinator. And then again, through the Department of Labor, the National Dislocated Workers Grant federal funding, they've provided us 7 more community program aides. We do plan to hire more staff to handle any surges in the future. Our department has already worked with the governor's office as well as BBMR and have requested to hire an additional 30 staff to help with investigation and contact tracing. In addition, within our department, across the other divisions, we are currently going to be training an additional 20 public health staff. This comes from like Division of Public Welfare, other divisions within our department to help augment our contact tracing capabilities. And then the University of Guam continues to expand on this extended pilot project that we initiated. And they plan to actually hire 5 full-time contact tracers, hopefully starting this week. They are still in discussion. Ideally, I know Mr. Carlos Taitano, who is one of our point of contacts, who is looking at hiring a total of 20. But right now he's hiring 5 and still in discussion about hiring the additional 15 men.
Okay, thank you, Annette. That was very thorough. So the 26 at UOG are volunteers and 5 might be hired permanently.
Yeah, some of the 26 are staff, ma'am. So they're the team leads. Yes, ma'am.
All right, and then for the Department of Labor, how long are their terms?
I was informed that they are 6 months, but there may be the possibility of extending them should we need them and if the funding is still available, ma'am. And actually through these Department of Labor participants, we've actually been able to try and get them on board as LTA. So there are some based on them already having the training and the skills for contact tracing. It'll be easier, seamless transition to get them on board through LTA funding under the ELC COVID grant.
Okay, great. And I know that those ELC funding and those are kind of at least 1 year, if not longer positions. Is that correct?
Correct, ma'am. We have 18 months as well as 24 months for those positions.
Great. And then the additional 30 that you mentioned that you've been discussing with the governor's office and BBMR. Can you describe that in more detail? How is that going to be funded?
That was our department put in the request, ma'am. And again, I look to my leadership to correct me, but I know it was to get additional funding, I believe through the CARES, to help us because of the huge surge that we had end of July into August. I initially was asking for 15, but thankfully to my director, he goes, no, let's increase that to make it 30. And so, to help us ease the burden as we continue with the huge surge and hopefully, God forbid, if there's any future surges down the road, ma'am.
Sure. Yes, and we want to open more businesses, right? So
yes,
we
ma'am.
want to be ready. So, Director, is this settled, or is this still being discussed, or?
Madam Chair, it's actually settled. The account has been loaded, and so they have actually recruitment. We have some starting today. We have some that are having different start dates. So this is beyond a discussion already. We've already got GG1s or notice of personal actions moving.
All right. What do you call them? Are these LTAs or is this like a regular?
No, they're unclassified, Madam Chair. They're unclassified, and it's contact tracers and EMTs.
Okay, and what is their term?
Right now, we have funding on the CARES Act with the 2 points. One is through the end of December to assist with the search because that's the CARES Act funding expiration date. And then we already in-house been talking last week to identify alternate funding within the department to support them past December. And of course, the request is also before the governor. She knows that she's very much aware, the team's very much aware of the December 30 date, closing date of CARES Act. And although there may be discussions perhaps in hopes and anticipation that might change or be extended, we're already talking in-house about vacant positions, given the need to keep these folks on and to address our surge, that we need to take a vacant funded position and use those funds for these individuals. So that is our plan right now, Madam Chair.
Okay, so when you say CARES funding, do you mean in addition to what you've already received?
Yes, ma'am. This is the CARES Act that is being managed by the governor's office or the governor and her team. So we received, I believe it was, ma'am.
Is this a $1 million extra request that was made or something above that, additional?
Just a moment, ma'am. This is the one that I had shared with you on a quick response that you had asked of me. All the paperwork here. Sorry, ma'am. It's, let me just get it here.
Yeah, but this is, so you received, according to the budget that we all saw, some money, about 500,000 from the 118 million. Then you requested an additional 3 million. And so are you now requesting more, or are you just trying to hire the 30 with that 3 million?
No, actually, ma'am, this was a separate request. The 3 million came in a different way in terms of overtime and paying for staff salaries and overtime and hazardous. And then we got, I want to say 475, hang on, ma'am, here it is. We received 495 to support the contact tracers and the AMTs. And so that was a recent request that I had asked for the response, in support of the response to the surge.
So is that what Annette was talking about, the 30 employees?
Yes, this is the money that we had asked for, ma'am.
495,000 for the 30 additional employees, and the 3 million was spent. You're saying you got 3 million allocated for overtime, like all the other government agencies, but not specifically. So we haven't expanded the Division of Environmental Health at this point.
That is correct, ma'am. Short of recent hires, just with the regular funding. So for FY20, ma'am, we spent 3.3 million in overtime and hazardous pay, and as of November 23rd, our overtime is 231,766 in hazardous pay for staff.
All right, but that was always going to be covered under the DOA's budget. The 3 million. What you had a whole list
Right, that's correct, ma'am.
Okay, then. So that's all right. Well, I'm disappointed for the Division of Environmental Health, because I know that now they're responsible for ensuring that the guidelines are enforced. And okay, but I'm glad that you will be hiring additional 30. I hope that happens quickly. And thank you, Annette, for the report on the rest. Okay, so during October 1st, the department reported the workflow was streamlined for contact tracing and containment. They could contact a positive case, close contacts, plan isolation, and instruct on quarantine for family members within 5 to 8 hours of test results. What is the current average time that contact tracing and investigations occur for a positive case? Are all individuals who test positive being contacted within 24 hours? Are we conducting the tracing and investigations within 24 hours and contacting close contacts? As I said earlier, my office still gets reports of people who have not been called by public. You could give us an update.
Yes, this is Chima. The workflow has been completed and adopted by the containment and the containment team and the surveillance unit. We developed a Google Sheet to track investigations, and that Google Sheet is a central place that cases are assigned and tracked, so that the leadership can actually see the status of the cases and also track investigations, so that we have an eye on what the contact investigators are doing. But currently, we cannot contact individuals using the estimated time frame of 24 hours because of the surge and the strain in our manpower due to cases of COVID-19 within containment unit. So it was taking us an average of 3 days to reach out to individuals who tested positive. But in response to that, the Public Health issued a guidance memo 2020-43 through a JIC release. This was to provide guidance to clinics on what individuals should do when they test for COVID-19. So the memo advised individuals to strongly encourage individuals to self-isolate, notify their household contact, and then reach out to public health if home is not conducive for isolation. And these individuals will be taken out of the home to the isolation facility, which is Bayview. And they were provided with a number, dedicated number that individuals can call through the 311 hotline to seek accommodation in the government facility if their homes are not conducive. And then regarding the cluster cases that affected our investigations. We prioritized more on the cluster outbreak investigations in the barracks and DOC, and then we had some cluster outbreaks that we are still investigating in some daycare centers on the island. And we also, with UOG, we did an outbreak management training with University of California. So 2 public health staff have been trained for outbreak management, and then we are also starting training for 4 staff tomorrow to complete the outbreak management training. And then we're also collaborating with UCLA and UOG to develop a Guam-specific training for outbreak response. So, and then, like I earlier stated, we are still having, in October, we could not make our 5 to 8 hours contact with the families, and we were able to do it within 3 days. But we try to make sure that individuals are properly informed using the guidance memo that was issued through the JIP. And then recently, on Tuesday, CDC came up with a new guidance for prioritizing COVID-19 case investigations and contact tracing. And by definition, Guam actually falls into the category of high burden, as CDC described it, which is a backlog of cases for each interviewer that is at least twice the number they are able to interview each day. So we are adopting that new CDC guidance with the recent outbreaks we have. So we're trying to prioritize our contact tracing. And we're looking at 3 categories. We're looking at high priority for people who have been diagnosed with COVID in the past 6 days, based on their specimen collection date or symptom onset. We're also looking at household contacts that have been exposed in the past 6 days, people living or working in congregate settings. And then we're also looking at high density workplaces like the barracks that we just concluded the outbreak management, outbreak investigation. And then we're also looking at another level, which is expanding to people with increased risk of severe illness, which was what Dr. Ann was talking about, by identifying those individuals who are at risk for severe illness or who have been part of the cluster. And then when we come out of this outbreak period, we're looking at going back to interviewing people who have been exposed in the past 14 days and also expanding to their contacts. So that's our plan moving ahead now.
Oh, I don't know how to tell you how this makes me feel. Okay, so you're saying because of the huge surge that we've had in October through November, and you're right, it's been over 4,000 cases since October, that we're no longer able to contact within 24 hours. Now you're looking at 3 days for the priority cases, and that's how we're going to prioritize due to the backlog. And that the rest, we're hoping to get to them within 14 days. Am I hearing that correctly? Is that an accurate summary?
No, so right now we're actually looking at prioritizing the cases that are 6 days old from the time of specimen collection and onset of symptoms. Because what we're trying to do is make sure we cut off transmission early enough within the household or within those congregate settings. But anyone that has been exposed in the past 14 days would have either been completely clear of the virus, and then to also give us time to reach out to their contact who would have also had that time period. But we're just trying to prioritize right now to make sure that we're cutting off transmission immediately we get the information that we need. Okay, 6 days now? Not. No, every individual that has been exposed within 6 days has to be contacted. That's what we mean.
Oh, okay. So these are for
High priority cases.
Okay,
Yeah, for
Right,
contacts,
right.
yeah, high priority.
High priority.
high priority contacts. Okay.
Right.
But, okay, so Director, can you just tie this in with your 30 additional employees that you're waiting for to hire now? How is this going to address that backlog?
Well, actually, there are two fronts, Madam Chair. The additional employees are going to be assigned to containment, which is isolation and quarantine, so they can do the contacts. But also, more recently, we reassigned up to 55 people within the department to now join the COVID-19 response. So I went within the department and identified 55 people, some at part-time, a lot of them at full-time, are now responding to COVID-19 in different parts. They include containment, so that was to respond to the search while we were onboarding EMTs and contact tracers. So, for example, this week we have 5 EMTs coming on board and 1 coming on the 7th. But we have, I have a list here, ma'am. We have 3 coming. Right now, the EMTs, I've got 3 starting to. They should be starting today, and I've got 2 coming later on in the week, and then I got 1 coming on the 7th. So we've got about 6 EMTs coming, and more to come pending, like police clearance and things of that sort. We're just waiting for some documents, and then we can have them on board. And so that would also.
Are you saying that those EMTs are going to be helping you with the tracing?
And case investigation, and especially with the containment section. And so they would also, they have multiple roles, including in the event we have another rapid engagement and team activity. We get data from Dr. Ann that says, hey, there's a situation here, and we're doing well with our contact tracing case investigation, but also having to balance that with a potential cluster. The rep team, including the AMTs, could be used. We won't use as many nurses. Like, for example, a home instead of 3 nurses would have 1 nurse and 2 AMTs, so the nurses can continue clinic work. So we're diversifying our workforce and adding on so that we would make best use of the staff that we have, the nurses doing clinical, and then our EMTs assisting the nurses in the field if need be, but also in containment and isolation.
So are we going to get to contacting those with positive cases within less than 3 days and the contacts of theirs within less than 6 days? Or are you saying we're pretty much looking at that going forward as our standard?
No, definitely not, Madam Chair. That's not the standard we're striving for. We want to reduce that timeline. That's why we added more people within our department to the workforce of COVID-19, made the request of the governor and her team and received some funding support. So that's moving forward. Chima hasn't touched yet on the SARA alert monitoring component, which will also shift some of the work so that those that are not at high risk will be on SARA alert monitoring, and those at high risk will stay with the person calling them to ensure and monitor their symptoms. And so we have those that are not at high risk. For example, our elder with diabetes would be our high risk, and they would actually have a person working with them.
Okay.
Sorry.
Well, I'm not even talking about monitoring yet. That's my next question. We're still on contacting the positives and the contacts of theirs. So yeah, very alarming actually. But can I ask then, what is the CDC? You told us at the last hearing, and I just don't remember that. What was the, that ideal time that they said we should be contacting? Well, never mind. I don't even need to go there. I think, yeah, and it seems very logical that the faster we can contact them. That's why we talked about the 24 hours.
Yes.
Yeah.
Ideal is 24 hours, ma'am. But the update that Chima was mentioning this past Tuesday from CDC is in regards to if there's a surge within your respective jurisdiction. And so that's why CDC came up with that prioritization. And again, while we're addressing the manpower to avoid future surges, but because we're in the midst of a surge and we're hiring bodies as we go along, this CDC guidance is across all jurisdictions where we need to prioritize because there's a huge surge and we're being overwhelmed. And that's where it comes in. Within the last 6 days, you still want to contact them and prioritize them from high, medium, or low risk, ma'am.
Okay.
But the goal is still 24 hours, yes.
Okay, thank you so much for that. All right, so Art, can you, Director, can you please just clarify? So these personnel that are being cross-trained from other divisions of public health, are they, you say you also got funding support for them. Are they being paid overtime then to help in this regard, or are they being diverted, for example, from CPS to work on contact tracing? Is that?
Well, we've taken on different approaches, Madam Chair. For example, I'll touch on CPS, and Terry can chime in later. They do their CPS work, and then after hours, they assist. Bureau of Management supported under the Division of Public Welfare. There's a team that also comes in after 5. And so we've got different approaches. To the point about overtime, yes, it is paid through the CARES Act. And so if they do work over 40, like every other employee, they are also compensated, ma'am. We've got some people that were 100% assigned just for COVID-19 response. And so we're taking different approaches to assist with contact tracing and case investigation.
All right.
So,
Okay. Yeah, I just want to make sure that if we've got some money that we get, employees that can dedicate, full time towards getting this backlog taken care of permanently. So no matter how many surges we have, we can handle it. But okay, I understand. And I'm going to move on to the, still we're on, contact tracing. So since October 1 to November 27, the surveillance report shows a total of 4,280 new positive cases. Of this, 946 positives were linked to household contact, 828 to workplace contact, 289 to community contact, 22 to healthcare contact, and 121 through quarantine of travelers. So about 52% of the new cases, the 4,280 cases, have been traced to, one of those sources. Does this mean that the remaining 48% of these new cases has not been traced to a source? Or does that mean that we've not contacted these people and we haven't been able to talk to them yet, or we were unable, and that's why we're unable to determine how they contacted the virus? How would you explain that?
Dr. Annette, you have a response for the chairperson? Dr. Ann?
Yes. I don't have that report in front of me, so I do not know. And it could be that a lot of the cases, we just don't know where they got it. That happens a lot. With other diseases too. Could be sporadic, and we just don't know. I don't have that exact, what date is that report?
Well, I think November 27th. So it's like 52% of the cases we're able to identify source, the rest were not. So I don't know. Annette, you had your hand up?
Yeah. There are some instances, Madam Chair, that yes, they do not know where they were exposed. There are, however, other cases where when they were initially reported, because they were tested at a different facility, that they didn't indicate that they are exposed to a different case. And so it may take a couple of days for the public health staff to connect the dots to a case. So initial report may be that no, they're not connected to anyone, but during the course of the contact tracing and investigation, we do kind of find out, oh, okay, you went to this location, or you're related to so-and-so, or you worked here. And then after their initial report, we find out they are contact to someone, be it at work or a gathering. So again, that information does change over time, ma'am, on the SITREP.
Okay, so when you would say that most of these have actually been contacted and you've tried your best to locate a source. It's not that we're not contacting them. Okay,
correct,
right?
Correct.
All right, that's what I want to make sure. Okay, and so then of course, all right, we talked about protocols for care, but I'm not going to get into that now. I'm going to allow my colleagues to talk about the contact tracing and the staffing of the contact tracing and the diverting of other personnel towards contact tracing and everything else that we've talked about here. So I'll begin with Senator Shelton.
Thank you very much, Madam Chair. I think we asked all the right questions here today, and I appreciate the information. If I can just get a really quick update about the COVID-19 app, what's happening with that? Are we seeing any progress with it, the amount of downloads, and its effectiveness in the community?
So, Senator Shelton, thank you for that question. We're pulling Janella to help assist with that answer. So just give us one. Yes. So she oversees this area and she'll be able to share the information with you.
Sure, thank you very much.
She's sworn in, that's correct.
We can see you. I don't know whether it's on this.
Or maybe I can go around in here.
Sure, we can switch places here.
We'll be able to see you. Yeah, the camera's not that good.
Yeah, you might. Just so that they can see.
Janella, sorry, are we waiting for Janella to be sworn in?
Yes, she just needs to be sworn in, Madam Chair. She wasn't part of the original group that was sworn in.
Sorry, sure. Is Mr. Enciak here? All right, Janella, if you proceed without being sworn in.
Okay.
Yeah, please.
It's okay.
Senator Shelton? Yeah. You had asked a question. Janella, did you hear the question? Yeah, go ahead. Go ahead.
No, I
Senator.
didn't.
Okay, hi, Hafaday Janella. I was wondering if we can get an update on the COVID-19 app, the amount of downloads we've had so far, and the effectiveness of the app in our community.
Sure, Senator. So as of today, we have 24,093 downloads of the Guam COVID Alert app, and that represents 32.91% of our goal. So our goal is 60%. So that's 32.91%. And since the beginning, since we've launched the Guam COVID Alert app, we've issued about 47 codes.
Okay, thank you very much. And so do you know how those codes, those 32 codes, how far they've reached? Have they worked to alert others that they were in contact with someone?
Yeah, so 47 codes. So in the beginning, some of the issues that we were facing was when we offer the codes, because of the adoption rate, it was a little bit low. And so when we offer the codes, some of the patients we were offering it to didn't have the code. Also, when we offer it, at the time that we're offering it, a lot of times the patients were still sort of in a state of shock. And so it wasn't really an ideal time. So we tried to come up with a system where when we offer it, we maybe offer it a second time. And then we tried to streamline operations, and which is something that we're working on now. So we have a 311 call center where, which we stood up at the very beginning. So people can call 311 option 3 to inquire about the Guam COVID Alert app. But we're now also, pretty soon, we're planning to roll out an operation where people can actually call into the 311 call center if they haven't received their code yet. Because normally what we do is we call them and we give them their code. We're planning to do a more streamlined operation where people can actually call in if they haven't received it and ask for a code.
Oh, that's great to hear. I'm happy to hear that, because I've heard several people who have tested positive who have shared with our office that they're actually, waiting several days for a code, and they're anxious to get it in so that the app can work for them. So I'm happy to hear that you're changing that procedure. And I'm wondering, what are the plans for the app moving forward? Will we continue to push the app and push downloads? And what will we do next?
Yeah, so we are still we've kind of scaled back the aggressive advertising of the app. When we first launched it, we didn't have an advertising budget for it, so it was really just a grassroots effort. And that was the campaign. It was just through word of mouth and working with our community. But we have kind of scaled back the campaign. But we are still, you know, in any way we can, whether it's a little at a time, when we get that opportunity, we still advertise it. You know, I still push it here and there. But we're hoping that with the 311 call center, just by means of letting people know that they can call to get a code, we're hoping that that would increase the code issuance.
Okay, that's great. Thank you very much. I'll be sure to do my part to share that information about the 311 call center and encourage others to continue downloading the app. Thank you very much.
Thank you, Senator. We appreciate your effort.
Thank you, Senator Terlaje.
Thank you. So just to reiterate, if you have been tested positive, you can call 311 to get the code to put into your COVID-19 app.
So for now, it's not something that we've fully advertised yet, but it is something that you can do. We do have people there at the 311 call center that will be able to assist you in getting that code. It may take a few steps, but eventually we're hoping maybe in the next week or so, that will be a more streamlined operation where once they call, they'll be able to just wait right there and within 15 minutes or less than that, get a code right away. But if you were to do it now, we might just say, you know, can we get your name and your phone number and the date you were tested positive? We just need to make a quick phone call, verify that information, and then we'll call that person back and we'll be able to give them a code right away.
All right. And this, okay. So, and again, so this is an app that we want to download on our phones so that we will be notified if we have been in the vicinity of someone who's tested positive.
That's
So
correct.
Get notified. Yes. And to help notify.
Potential exposure, right. If your phones were in contact with another phone that registered a positive diagnosis. That's correct, Senator.
All right. Thank you, Senator Shelton. Senator Taitigui. Senator Moylan.
Thank you, Madam Chair. A couple of questions. First one for Janella, while she's still on the code alert there. I did download it on my system, and just going back to what you said. So when I press the button and, you know, stop the spread, verify, then I had to verify my diagnosis by entering that code. It's an 8-digit code, and that's where I stopped. So of course, what you're saying, hopefully, if you're thinking of the 311 where I can call up, but if you put that on the phone to say, call 311 for your code, maybe that will be helpful, because I have no idea who I'm supposed to call if I did need the code, and then I'll forget about it. But if it tells me right there, that could make me want to do it instead of just forget about it. So just a suggestion, because right now, if I understand correctly, we have over 20,000 people that loaded up the system. We're short our goal, but we're hoping to achieve the goal. But of that 27,000 or 20-some thousand, only 47 codes were given. Only 47 people out of the 20,000 people. So I think your idea is a good idea. And if you could put, who do we call for that code on this thing, I appreciate that. Unless you guys got something better idea, but it just came to my mind. But I thank you. So it wasn't really a question, but just a statement. But I do have a question there, Madam Chair. This question is for Annette, basically on the contact tracers. So we were talking about Department of Labor, and I'm looking at a press release they did back on September 14th, where Department of Labor is going to hire 24 individuals through 12 for data collection clerks and 12 for community program aides, 6-month term, $10.14 per hour. And this is all through the Dislocated Worker Grant. So 24 individuals. How many have we hired from this grant out of the 24 individuals?
Sorry, Senator. Specific to the contact tracing investigation, we have 15. And then we have others who are just data entry clerk, and we've had some turnover. Actually, there were some who were called back to their regular job, which is great. Then we've had some who had to unfortunately quit 1 or 2 weeks in. There were challenges like with babysitting, childcare. And so we did lose some, but our point of contact at Department of Labor works diligently to replace when we let her know we need more assistance. So we've actually received more than we've put in, because we've also had some Department of Labor participants be assigned over for like logistics, as well as for data entry and other sections of our command structure, sir, for the COVID response. So specific to ours, we have 15 for contact tracing, and some of them are actually promoted up to be investigators because they're eager and they're motivated. And so, and those are the ones that we've actually are slowly onboarding through the ELC COVID grant funding for LTA positions. So again, as we lose them, because we're promoting them up and we're getting them on board for a longer period of time, we are requesting through Department of Labor for additional bodies to replace those that we've lost.
Okay, I understand. Thank you very much. Thank you, Madam Chair.
Thank you. Senator Taitekwi? All right, we'll move on. So just a couple more.
Sorry, Madam Speaker. Madam Chair.
Sure.
Sorry.
Yes.
Actually, I think the question was already asked earlier by Senator Shelton. So no, it's okay. It was already asked. Thank you. I marked it off. Okay. Thank you so much. Okay.
All right, Senator. Okay. So this is regarding monitoring, right? Those who've tested positive, especially those with prior health conditions. We had a discussion at our last oversight hearing regarding these persons and whether there was more that we could do for them, knowing that they are at high risk, and especially the death statistics that we have seen. So we talked about if a person was in government-funded isolation facilities, they were receiving, nurses monitoring more than once a day. And we were told that those at home were receiving at least once a day, sometimes twice if they had enough personnel. Has there been an increase in monitoring of positive individuals who are isolating at home? Are there, have you seen any increase in those willing to go to the government isolation facilities since our last oversight hearing, or since your outreach is what I'm hoping? Because at the time of your outreach, very few of them went into government isolation facilities. Most of them stayed home. I'm talking about your rapid response outreach. And so since then, I guess, have we been successful in convincing more people to get into the government isolation, especially those with risk or who need increased monitoring? Or have we taken care of them in another way? If you could describe that.
So I'm going to, Madam Senator, I'm going to answer on the enhanced monitoring for individuals with comorbidities. But what we did was, after our last oversight hearing, the containment team sat down and looked at all the different categories of individuals we monitor. So what we were able to do was, for the ones who were asymptomatic and were much younger, due to the cluster outbreak, we started moving them to passive monitoring using the Guam response, which is the Sarah alert for passive monitoring. And then for the elderly who had comorbidities, we had a meeting with the Division of Senior Citizens and their contracted case management service providers to look at how to provide enhanced monitoring for seniors that are diagnosed with COVID-19. Our goal was to provide enhanced monitoring for them and try to mitigate against them developing complications. This program was actually designed in a way that the case managers will provide support and wraparound service. The Division of Senior Citizens already have a program that actually assists the elderly who are 60, 55 and above. So we're trying to tap into that process by working with their case managers who actually call them and try to manage them. So we're using that structure within the public health by identifying all those elderly people who are COVID positive and enhancing our monitoring with them using that service. So that's what we've been able to do. So we actually had a meeting with the Division of Senior Citizen and the contracted staff on how to implement the program. We've actually come up with a criteria, but it was delayed by the surge. So now that when we come out of the surge, then we can now focus more on how to enhance monitoring for the elderly that are susceptible to developing complications due to COVID.
All right. Well, that's great innovation. Thank you for that. Now we just have to find for the younger ones, I guess, because we're seeing a lot of positive cases in the younger groups that they're not quite eligible for the senior citizen services.
Okay.
And
You need information on ISOFAC? We have Oversight right now.
So yes, the younger ones are actually being put on the passive monitoring using the Guam response. So and that is it's easier for us to reach them, and then they can respond right away. And it's daily and it's time. And the response team will be able to move in and intervene.
All right. Chima, we had been told after the last hearing that Public Health had purchased the oxygen and pulse monitors for patients to take home. Is that correct? Or how do you disperse those?
That is for Xenia.
That's Xenia, yeah.
That's a Xenia question.
Oh, okay. Those are for the nurses to be using. I think, is that at the ISOFAC or for their home monitoring?
I think it's going to be the ISOFAC, not home monitoring.
Okay. All right. ISO facility. All right. Then, okay. I think, yeah, I'm hoping we can still do more. I know we might be maxing out our COVID 118 million, but I'm still hoping we can do more as Dr. Pobutsky's information becomes public, you know, regarding the diabetes risk factor and how it has led to so many deaths. I really want to help increase monitoring, I guess, of these patients. But thank you for all your efforts in this regard. Are there any questions from my colleagues regarding the monitoring in the ISO or home facilities? Okay, so we'll move on. Before I move on, Annette, can I ask you one more question? If you hire the 30 more people, right? Is that just to take care of the backlog, or is that going to help you to be able to respond to additional surges?
That will for both, ma'am. But hopefully as we move into the vaccination phase, we can prevent future phases. But yes, those individuals will help for both.
All right. And so do you think it's enough, or do we still need more?
We've actually had more through UOG, more trained up. And again, I know DOE is really pushing to have more dedicated within their respective schools to expand that out. And so I think, ma'am, as we continue to train more people in our department and other agencies and key partners, by them helping us again, then we should be sufficient, especially with the additional bodies being hired through the EOC grant, as well as through our leadership and the support through the governor for the 30 bodies, ma'am.
Okay, I certainly hope so. Thank you. Thank you. And okay, next questions are regarding the enforcement of the public health guidances. Oh, sorry, Senator Moylan.
Yeah, thank you, Madam Chair. Sorry, I had a question regarding the hotel isolation. Would that be appropriate to ask now?
Yes, please.
Oh, okay. Just the concern will be, as of the end of December, the CARES funding will no longer be there. And just wondering how is public health then working if we're not going to have these visitors or people returning home, going through the hotels, of course, they're going to their destinations. What is the adjustment that public health will need to be doing, or is this fine? You got it under control? Just wondering how you're foreseeing this to play out. Thank you, Madam Chair.
Senator Mullen, already on October 5th of this year, the public health started using what we call the travel monitoring system by Sarah Alert. So for every individual who arrives on Guam and is in the government facility and gets tested on the 6th day, if they are negative from COVID and they are transferred to complete quarantine at home, we actually send them, we actually register them on Sarah Alert. This is a passive monitoring system that they report into every day. Currently, we have, we've registered 3,397 passengers on this system. And since October 5th, we've discharged 2,885 people that have completed the 14 days of quarantine monitored by public health. And currently, we are monitoring 512 travelers on this app. This is independent of the Guam response, which we are using to monitor individuals who are actually laboratory confirmed positive cases and their close contact. So we have that system in place already, and we're using it to monitor individuals travelers coming into the island.
Oh, okay, I see. So basically, if the hotels were ended, then you already have this Sarah Alert in place that will continue on with their monitoring, correct?
Yes, sir.
Okay, thank you very much. Thank you, Madam Chair.
Thank you. Thank you, Chima. All right, so as to the enforcement of the public health guidance, first of all, has the department or the Division of Environmental Health received more funding or resources to be able to increase its capacity to monitor and regulate businesses or civic organizations' compliance with the public health guidance?
Thank you, Madam Chair. Yes, with respect to funding for overtime, night differential, hazardous differential pay, that has been allotted to the staff of the Division of Environmental Health. In addition to that, even though we've had at least 5 staff that have been reassigned to assist in the Department of Public Health and Social Services, incident command systems, COVID response activities, we have had 3 part-time staff assigned to us to help augment that reassignment from other division bureaus, as our director had stated earlier. So they have been helping us with as far as our data management for COVID-19 inspections.
Okay. So
in addition to that, I'm sorry, just one last thing is we did recruit for 2 new environmental public health officer staff. They were recruited and they reported in November of this month.
okay. All right. And so 5 were reassigned out, 3 were reassigned in. You've got 2 new recruits, but still kind of almost the same level that you were. Okay. All right. And I know that Mr. Nadeau like you said, was reassigned to other parts of the team. Okay, great. So this, are there plans to bring in any more for the upcoming year?
That's actually a great question, and we actually forwarded a recruitment package for our vacant funded positions to our director as of just this month, November. For the 3 staff, we lost 2 staff actually got promoted effective October. So their vacant positions, the environmental public health officer 1 positions, there were 2 that were promoted. Those recruitment packages have been submitted to our director's office, as well as an environmental public health officer 3 and a customer service representative supervisor. So those are positions that we did forward to our director.
Okay. All right. Thank you. All right. Is it your division that's going out and ensuring whether businesses are complying? And are you doing that on a complaint basis, only when there's a complaint, or are you doing that regardless of complaints?
That's a great question. And I can respond by saying that since the governor executed the declared the emergency in March, our division has been the primary lead agency to go out and inspect for COVID compliance. And we've been doing it since March. We respond to both complaints as well as addressing routine inspections for both COVID and sanitation inspections. We try to fit that in as well for both health regulated and the non-health regulated. establishments. So we're doing all businesses, not just those that are permitted by our office. And a total, we've actually inspected a total of 1,390 inspections since March to November 23 to 2020. Of course, we've had a lot of businesses that were closed. So we were making sure that even with the executive order and the guidance policies that were written and adopted by public health, that there were certain businesses that were considered non-essential. We were making sure that they were not in operation. So a total, we've done about 4,236 compliance checks, but we were able to inspect 1,390.
I'm sure that's a record, right? For your division, because in previous years, the inspection rate was quite low because of
That's true.
All right, so what about, so now that the new guidelines for enforcement are out, those have been made final by the director, and then, or the rules and regulations, right, or what they were called. And
Correct.
do you believe those are going to be effective enough to prevent the spread of the virus between employees and employers?
We definitely believe it to be effective. I mean, we have now I think the strongest provision here is the penalty provision. And we're really hoping, I mean, it's not our intent to go out and impose penalties on any member of the public, but it's there to help deter and curb the number of violations that we do see, because usually when we go out, we will see violations. We've cited a total of, we found a total of about more than 600 COVID violations, whether it's a failure to use a mask, it's failure to social distance, failure to post signage at the entrance alerting consumers or customers about the need to have a mask and social distance, or just even not having a written policy in place, or even just failing to adhere to the public health guidance memoranda. So we have all of those criteria that we have been looking for and inspecting, and we have been citing it even without when these regulations were not in place.
All right, does anything in these rules require employers to contact or to notify employees if there's a positive case within that establishment?
Not in these regulations, Madam Chair.
All right, Annette, does that require, I mean, is there any mandate on employers?
Not for us that I'm aware of locally, ma'am, but I do know in the US, Equal Employment Opportunity, they had mentioned that the employer should inform their employees of a positive case in their organization, and that employers are also able to require testing of individuals that they're hiring or for employees to come back into work. And that's something at the federal level, ma'am.
All right, okay, thanks. Colleagues, any other questions regarding their new rules and regulations or their enforcement capabilities? Senator Taitigui.
Thank you, Madam Chair, for the opportunity. Regarding those rules and regs that were put in place, you know, I was trying to look over the legislation, or not the legislation, but the law in Chapter 19 that actually gives the authority for the Department of Public Health to implement these rules and regulations. But I have not seen anything from the Attorney General's office with regards to the ability to do so. It's almost like public health is acting as, or at least with the governor's office moving in that direction, is acting like the legislature at this point when it comes to implementing these rules and regs. Do you have anything from the Attorney General's office that states that what you're doing is in compliance with Chapter 19?
I could ask our director, but a comment I could make is that we did have a meeting with the members of the Attorney General's office. As a matter of fact, we were also provided a copy of the draft regulations. Whether they had separate meetings with our director, that's something I could defer to Director Sanagasti.
Yeah, good afternoon, Senator Taitigui. Yeah, we're basing most of our activity on the executive order authorization. And I can go back and look at my communications with regards to your specific inquiry with regards to anything from the AG's office that says that we are operating in line with our public health mandate for public health emergencies. And I can look at that. for.
Yeah, particularly the law that is cited that gives you the authority to implement such rules and regulations will be helpful, just so that because we're getting the, Art. I know you guys are doing everything you can to deter people from not wearing their mask or congregating or not following the guidelines, and I agree, but there's some questions as to what gives you the authority to do so, and I just want to make sure that we're on the same page when I do speak of those rules that the Attorney General has had an opportunity to look at and quote that particular law and section that gives the authority to implement rules and regulations outside of the legislature's jurisdiction with regards to that. So appreciate that if I can get that as soon as possible. Thank you.
Okay. Okay, Senator, just so we're clear, because the question is that there is a section within the public health guidance as 19802, but you're looking specific for something the AG's office may have said that your rules do give you the authority to regulate, create and input regulations for. Is that correct?
Right.
Just so that
fines, to put fines, to allow for fines, citations, etc. That's outside of the normal AAA process with regards to this.
all right.
Okay.
Okay, I just wanted to be clear. Thank you, Senator.
Thank you. Thank you, Madam Chair.
Ms. Rabago, you had your hand up.
Oh, yes, I was just going to state and support the director's position with respect to section 19801 and 19802 with respect to the Emergency Health Powers Act authorizing public health to promulgate and implement rules and regs, and also impose fines and penalties pursuant to the issuance of these regulations. So, but I hear where Senator Taitugui is coming from with respect to something specific from the AG's office. So thank you.
Thank you, Senator. So, Director, do you think that the recruitment package that was sent to you, that you're going to move forward with that and actually recruit those people for the Division of Environmental Health?
Yes, absolutely. I'm pretty confident. These are positions that were funded. Actually, there was one also that Rosanna, you had a resignation from Catherine. So we also had an employee that had resigned, promotion, private company, I think, but not, or federal agency, I believe. So those positions were funded in the budget. And so it is our intent to push those positions forward. I also wanted to share with you, sorry, that's okay, sorry. Yeah. So we are intending moving that forward, Madam Chair.
Okay. All right. So, okay, I'm moving now on to, these are kind of miscellaneous, my remaining questions, and then of course my colleagues. I wanted to know, so you've implemented today a new strategy. We saw the announcement in the news of this new mass testing strategy, and I heard Janella describing it this morning. Thank you, Janella. That was very clear explanation. So she described that we've got 30,000 tests. These are the rapid tests. We can get answers in 15 minutes. They're going to be notified right there at the testing site, whether they are positive or not. These are the antigen tests, and these were reported to be a little less reliable than the other tests that you started with, right? That go through your labs. And but I guess the Surgeon General or Dr. What's her name? Dr. Burks. Yeah,
Deborah Burks
suggested that better to do this mass testing, gets maybe 60% results versus waiting any longer and holding off. But anyways, yeah, just so these are different strategies that you are implementing together with, strategies we have seen in the past, the mass testing, the targeted testing, the rapid response to, very targeted testing and different things. So I appreciate that public health has to, adapt itself to CDC changes, other recommendations, and just our community's changes. So, but I guess I just wanted to know, is this, it was said that you're going to be looking at this for the week. After the week is done, then you're going to reconsider a strategy. Could you just share with us what other possibilities, very briefly, just that we might be seeing, and what might convince you to go with that certain strategy or not? Are
Okay,
we,
well-
I mean, they had described
Sorry.
this morning again, that you are done with for the meantime, with this targeted rapid response testing to certain communities, despite there might be still some hot spots. And I'm, very curious to see Dr. Probutsky's information, but so we're moving this way. If you could just give us some more detail, but more to let us know what we can expect moving forward based on this type of logic and strategy. Yeah.
Sure. So Senator, what I mentioned this morning was that based on where we're putting our resources, at least for this week, of course, the focus now is on this mass testing. We have 3 sites throughout the island. And that's as you're well aware, a huge resource that we're using, which would obviously put a sort of pause on doing the rapid engagement testing, if you will, that we've been utilizing or we've been doing. But at the end of the week, we'll regroup. That's the plan. We'll discuss based on, depending on how this week turns out, how we're going to move forward next week. And the goal really is we want to make this as available as possible. So, but depending on how well the turnout is this week, whether we're going to scale it back, if it's going to be every other day, or if we're going to continue to do it as a daily thing, that's something that we're going to discuss at the end of the week. So as far as the rapid engagement team, the targeted testing, the active case finding, I think that's still a goal of ours, but just how often or how frequent we do it, whether we do a smaller scale version of it, that's also something that we're discussing as an agency. And I don't know, Director, if you wanted to add to that.
Yes, so thank you, Janela. So in addition to that, Madam Chair, we are also working with our primary clinics. We are just about completed with a questionnaire and a press release that will also be speaking on the Binax now tests and the antigen tests. And we are also going to be partnering with our primary clinics so that they too can offer the Binax tests at their clinic sites. As Janela had said, the rapid engagement team, if we need to deploy them based on data that we get from Dr. Probutsky, that's an internal adjustment we'll have to make. And she is correct. We are going to look at this week and see how things go. Today we had in our 3 sites, 300, these are tentative numbers right now coming from the incident commander. That's where Tom Nadeau has been assigned. He's our incident commander for COVID-19. Early data right now is showing 315 individuals were tested on the Binax today, and of the 315, we have 5 positives. So that translates to 5 individuals in community now that are in isolation, and will also be assessed if home isolation is not suitable. Of course, we would offer them the government isolation site. So we are going to look at this. We were initially planning for a span of 2 to 3 weeks. We're really wanting the community to know there's an option for testing. It's at no cost. This is not restricted to just the residents, private residents at home. We're looking at the individuals moving in the community. We're looking at the business community. If a company wants their employees tested, we can coordinate. Today was a pretty slow day for Agate. So the incident commander and I were thinking that perhaps Agate could be a possible site for business communities to coordinate for their staff to be tested through the Binax platform. And so we're still maintaining the testing at the Community Health Center at our northern site. And so once we reopen the south, we are also going to be putting that forth also to have testing down at the southern health center. So northern right now has been heavily focused on close contacts. We will continue that. You mentioned earlier about the construction industry. So Northern Health Center also served as a test site for many of our construction situations, but also we had the rapid engagement team do a construction site test on I think a Saturday or Sunday. I forget the exact date. Was it a Sunday?
It was a Saturday.
It was a Saturday? Okay. So we're going to still do the health centers. We're still doing the Binax, and we're still working with our labs. And we've also have lab capacity. In the event we are beyond our capacity at the Guam Public Health Lab, we have contracts with DLS, and also GRMC should be also in place so that we can send specimens there. So we're really looking at continue to build our capacity, Madam Chair, so that we can accommodate the tests. We're really wanting to find those that are positive so we can interrupt transmission as much as possible. so that it doesn't have any further spread in our community. And so that's what we can look for in the coming weeks, man. And just one final thing, only because you all hear about the vaccine, we don't have a definite date, but we are definitely staging ourselves for that. And so when the vaccine comes, we will then be shifting our focus so that we can vaccinate our healthcare, our frontline responders, but also our elderly and the other high-risk populations. As you may have heard, there's a request for those with diabetes because they are the ones that are, in terms of those that have passed on, the comorbidity, that's the highest. So that's on the for consideration, of course. And that's where we're at right now, Madam Chair.
Okay, so in relation to this testing being done this week, the decision that you will be making after this is done, your assessment, is this being done by public health, or is this decision going to be made by someone else?
Well, public health leads the decision-making process in this. We do share it, of course. This is a plan that the governor, lieutenant governor, and the team that we consult with we confer with, is aware of. But the decision, like I was sharing earlier, I spoke with Tom. I said, hey, it's our first day. We were positioned to do more testing, but it's good. We got 315 people come in that wouldn't have been tested, and we've got 5 positives. Of course, would have been great if they were all negative, but we did have 5 positives, and we will continue to move forward. And so Tom and I were thinking, well, we're like, should we change the position in ag? And I said, well, actually not right now. It's only been day 1. The work continues to get up. I'm hoping people are going home tonight saying, hey, it was a pretty quick process. It wasn't as long, and you got your test results today. So maybe as that becomes hopefully table conversation for our community, that more and more folks will come out, and that we'll maximize the 200 per day, Monday to Friday, and 300 on Saturday, which is through this Saturday, Madam Chair.
Can you clarify, do you mean 200 per day per location, and for a total of 600 per day?
Right, correct, ma'am. We are positioned today to test 600.
Okay, great. Yeah, that's a
200 per site.
A huge amount, huge shift. And okay, so let me just ask a couple more questions. So when they are tested positive, so the 5, let's walk through these 5. They were determined positive within 15 minutes while they were there. Do you counsel them as you would if you called them up and told them all their options for quarantine, for isolation rather, and then for contact tracing?
Sure.
Do you do that?
It's a very good question. And Janella is I know she's nodding her head, so go ahead.
Yes, so we do have members of our isolation team there at each location. So anytime there's a positive case, a nurse will give them a call and let them know that they're positive. We'll give their results to them and let them know that they're positive. So we have a member, we have the ability to provide the results on site. Some people have chosen not to wait, maybe they're on their break or don't have time to wait on site. Some of them will just leave. But if they're positive, the way that we do the method is a nurse or one of our team members will go out and point to the result. They won't verbalize the result. They'll give them a sheet of paper with the results on that paper. Now, if they're positive, we do an additional phone call to them to let them know of the instructions for isolation.
Okay, so they're not being right there and then about isolation, only that.
Right, so initially what we want to do is ensure that they need to go to home isolation first. And then at a later point, somebody from our isolation team will give them a call to let them know their options for isolation, that, they make that assessment. If their home is suitable for isolation, then they can stay in home isolation, or if not, then we have the isolation facility available for them.
Okay, I was hoping they would be counseled right away rather, as to isolation. And what about then the contact tracing? Because in prior oversight hearings, what we were told was some of these people you were not able to contact after they left the clinics because faulty information, or they didn't give you correct, phone numbers, or they didn't have phones. And so that this is are we going to, so this opportunity is not being used to get contact tracing information either?
Did you guys sit on the planning for
I think that's a general question.
For contact tracing, no, but for follow-up, yes.
Yeah,
For-
So,
It's on you.
yeah, you can speak.
okay. All right. Madam Senator, during the planning meeting, we agreed that for every individual who gets tested, their information is taken on site so that we can actually reach back to them if they are positive. So we can actually enroll them right away on Guam response, the monitoring tool, while we also follow up with a notification of result if they are positive, so that we can
Right, but you're describing a phone call afterwards, not on site, right? I'm asking about on site.
If a person, if they go through and they're test positive right then and there, can you give them the option of quarantine?
Because they're
isolation?
positive, so we
Yeah,
can
can you,
offer them.
I was asking whether I had asked Janella whether you talked to them about quarantine or isolation. She says, no, that's when they get home, they get a phone call. And then I'm asking
No.
about,
To clarify, Senator, we do. We do
Yeah.
counsel them right away.
Okay.
And what we let them know is that they should isolate immediately at home. But what, in addition to that, and we've already put out material on this in our JIC releases through social media and through the media, is that if they're unable to isolate right away and they haven't, for example, when they receive their initial positive result, everybody is always counseled about home isolation or self-isolation. And then they're given further instructions that a team member from our isolation team will call them later down the road to give them more instructions about isolation at our isolation facility. But in the meantime, if between that time and that second point of contact, they feel that they want to go immediately into our isolation facility, they have the option of calling 311 or a second phone number at the overnight hours, which is 998-4512, which we've actually received phone calls, and they can be transported to the isolation facility. But that initial contact, once they're positive, we always give them instructions for home isolation. And that's, stay away from anybody who's negative. If you have a bedroom with its own bathroom, then isolate in that place. Make sure you don't share that space with anybody else. We have educational material that states all of this, that we've issued several times in our JIC releases. It's on our social media pages. And we've also, through word of mouth, we've discussed this many times.
all right. So is it possible to, when you're informing them of their results, also to have someone talk to them and get all the possible contacts right then and there while, they are available to you, as opposed to making a follow-up phone call? Just wondering if that can all be done on site or not.
we did it with the RAT, and I wasn't on site today for the initials. That's why I can't give you the concrete information. But during planning, we actually agreed that there will be an on-site CI team, that is a case investigation team, and a containment team that can actually isolate right away.
Yes.
Because what we do is, when an individual tests positive, they are offered the government isolation, or they are actually interviewed to make sure that their home is suitable. So we had that as part of the plan, but I wasn't out in the field today to confirm if we, out of the 5 positives, if this actually happened. But we have it as part of our plan to have the CI team and containment unit out there in the field. That's the reason that's part of the reason for the consolidation. When we talked about merging the case investigation and isolation unit as one. This is one of the reasons.
Okay.
Yeah.
So, Madam Chair.
That works out. Yeah. Director? Yeah. Yeah. I hope
Madam
that
Chair,
works.
yes. Sorry, Madam Chair.
Go ahead, Director.
Okay, so I just spoke with also Vero. We had 3 leads. Al was the lead over in the GIGO, and Terry and I also went to the different sites, and we also met some of the staff. And there was a social worker on site, so I just wanted to clarify before we share this information that to your inquiry, that yes, in the event that they needed to do an assessment on the spot to have the person who's positive move into the isolation facility, that can happen on the spot. There is a social worker, they'll work with the person's positive, may need medical attention. Of course, they'd be referred for that proper attention, or they can make arrangements if they feel like, well, I want to isolate at home. So they'll make arrangements with the social worker to get the call back, which I think is where Janella was also referring to do an assessment if the home is suitable. But if the person says, I have one bathroom, there's 6 of us in the family, there's no way that I can isolate myself and not potentially infect my other family members, then the ISOFAC will definitely be an option at that point. I hope that answers your inquiry, Madam Chair.
Yes, that's good. I'm glad if we can do it all on site, because I know that you had raised before that, we lose contact with them when they.
Yes, you're correct, ma'am.
So that would help. And I think encouraging more isolation would just seem to, I can't imagine that the percentage of people that are home isolating really is the true percentage of homes on Guam that are equipped for isolation. I don't know. That's my lay person's interpretation of that. So I feel like we need to encourage much more this government isolation, true isolation to prevent spread in the families. But that's just my suggestion. So along this line, so we have your new, Chima explained earlier, and you had explained prior, on the new quarantine policy. Different number of days, testing is involved. So when they are, when someone's tested positive in a quarantine facility, but they're not symptomatic, are they mandated to go to the government's isolation facility, or are they allowed to isolate at home as the rest of the community is allowed?
So we initially mandated individuals who tested positive in the government quarantine facility to isolate in the government isolation facility. But we had some court rulings that allowed individuals who were asymptomatic and they had a conducive home to go home and continue their quarantine isolation, and were monitored by public health. So what we normally do is that the home assessment is basically where we determine if an individual can successfully isolate without spreading the virus within the community. And if that determination is made, public health will go with that judgment and also continue with monitoring until the individual is cleared from isolation.
Thank you, and for clarifying that. And so that came about with some court cases, and we've just adjusted our policy a little bit. Okay, what about, you talked about, Chima, a potential for, are we looking at, I think I saw in New York or some other places where the travel quarantine protocol was, they test them after 3 days, I think, and then send them home to finish their quarantine. And if they test them again with a different test, a more reliable test after 7 days, and it's still negative, they're cleared and they don't wait for the 14 days. Are we looking at anything like that in the near future?
Never heard of it. No, and we're still not using I think most of the jurisdictions base their recommendation mostly on size and their capacity. Like right now, what we're doing, we're able to maintain the 14 days and successfully monitor them. And for now, that is what we're doing. We've not been able to come up with another strategy for that.
Okay, so just repeat it then. Well, you talked about using these tests, or sorry, didn't you, or did Janella talk about using the new antigen tests to test arrivals, or are we too premature to talk about that?
I'm sorry, did you guys talk about arrivals already?
Oh.
Travel maybe?
Fine. We won't talk about that today. I think that's still a policy being developed, right? That was a potential use of the other, yeah.
Madam Chair, I know I have a meeting tomorrow with a team, I believe it's at 3:30, and it's on the travel protocol at the airport. And so but that doesn't start until tomorrow for that discussion.
All right.
I'm not sure maybe when does that? I'm not, did you guys talk about it?
No, I think it was just mentioned as another potential use of these antigen tests. Yes.
I
And
got
know
asked
that-
about it this morning.
Madam Chair,
Yes.
if I may, I don't know if this is appropriate, and so if I'm out of line, please, I'm all right for you to tell me that. I have a 4 o'clock, another COVID-19 meeting, but I do have 2 deputies here and my very trusted team and very knowledgeable at that. If it would be all right with you, Madam Chair, that I be excused for the remainder of the oversight?
I'm pretty much done with my questioning. I have a few more comments to make, but could I just ask my colleagues, does anyone have a question specifically for the director? If not, we'll continue. All right. Thank you very much, Director, and thank you for all your work. And please keep it up and let us know how we can help. And we will just.
Thank you very much, Senator. Thank you very much. Thank you, Madam Chair. Now we go to we have an insurance. And COVID-19.
All right, okay. So, so just to follow up, so we're doing isolation kind of counseling on site. Hopefully contact tracing can be done on site also. If we can get that going while we're doing these mass testings. Now, just back to the tests again. So we're telling people if they test negative that they're safe to go back to work if they think they've been exposed. Are we counting these tests as reliable in that way?
No.
In the long run.
Who's talking now?
Okay.
Go ahead.
So what we're, part of our education.
Okay, Janelle.
Yes, Madam Chair. So part of the educational campaign that we're going to be rolling out soon, and we've actually put out some educational material on this as well. If you're a close contact and you get tested, even if you test negative, you should still remain in quarantine for the full 14-day period. If you're not a close contact and you don't have any symptoms and you test negative, then you can return to your normal activities. However, if you do have symptoms, you're not a close contact, and you do have symptoms, you should consult with your physician on what your next step should be. So close contacts, regardless of the result, well, close contacts negative, you should quarantine for the full 14 days. But if you're positive, then obviously you should go into isolation.
Okay. Should we be recommending that those who are actually close contacts be tested elsewhere? For example, with the Abbott test or at the Northern Clinic labs, and restrict those who are close contact to that type of testing, or continue to allow them to do this antigen testing?
Well, I think, regardless of where I think whatever is available as a means. I don't think we should tell people that, you should only get tested at one particular location or one particular site. Whatever is available as a means is what you should get tested, or where you should get tested. Because a nurse or a physician would be able to make that determination whether or not, for example, if it's the Buy Next Now, they'll be able to make that determination whether or not you need to get a second test done with a PCR.
Okay, so when is the physician or nurse making that determination?
So like, for example, if it's a symptomatic patient, and it's
let's talk about an asymptomatic close contact who comes in for the binary test, the antigen test, right? This mass testing that we're doing. They are close contact.
I think Chima
asymptomatic.
might be able to.
So, ma'am, by definition of close contact, anyone who is a close contact to a laboratory confirmed positive case should isolate for 14 days, even if they test in between and they are negative. As far as they are determined close contacts to the index case, they have to complete the 14 days of quarantine. That's the definition.
Okay, yeah, you're right. All right. So, and are you still, public health is still making appointments for everyone who they call who's a close contact to come into the Northern Center to be tested? Or are you telling
Yes, that's correct.
All right, great. Okay. My final question was just that the governor extended the public health emergency after Thanksgiving. Did you recommend that the health emergency be extended, and what factors? She listed factors in the executive order, and I just wanted to know if you concur with those factors or if there are any other factors that we should be looking at as well. The director stepped out, so Deputy Director Ugin, I guess I'll look to you.
Sure, absolutely. And yes, we do concur. And, you know, our numbers here on Guam still remain high, although over the last few days that they are just slightly going down. So it's still very concerning as to our numbers, and we want to remain proactive. That means we stand ready, and part of that stand ready is to make sure that we have everything in place. With this, we are allowed to use the Guam National Guard, Army National Guard. And of course, that allows us the manpower that we need to help facilitate some of the different outreach sites that we have, of course, isolation and quarantine, as well as addressing other issues. Definitely the means of enforcement. As you know, many states around the United States, of course, has very high incidence as well. So we really want to aggressively go after this and lower our numbers and, of course, lower the numbers of fatalities that we have. So yes, we do concur.
Okay, thank you. Anyone else want to add anything to that? All right, so if not, I'm going to ask my colleagues for their miscellaneous questions. Senator Shelton, are you there? All right, we'll come back to Senator Titesweet, please.
Thank you, Madam Chair. Director, again, you mentioned that you concurred with the governor's executive order to extend it to another 30 days. And you also mentioned that you noticed the numbers are going down, you know, they're lower. Have you agreed to any of the other businesses opening up, like bars or lifting of some restrictions as well attached to this extension? Have you made any recommendations? For instance, particularly some of the bars.
Right. And thank you for that question, Senator Titlegy. We actually have not. You know, our numbers may have gone down slightly, but that's no green light for us to go full force doing anything other than what we're doing now, making sure that testing is made available in the community. You know, at the end of this period where we're doing large numbers of community testing, you know, we'll continue to look at those numbers, let data, let science guide us on our decisions. And if the numbers are looking good, then maybe, you know, this Christmas will be a little bit more promising than our past Thanksgiving. I know it had quite a number of restrictions and limitations, but no, we're not considering bars at this time.
My next question is, you talked about Christmas. Now that's before the end of this new extension. So is there any possibility at all having some restrictions lifted within the next 2 weeks at all, considering you're still looking at data? Is that a possibility?
You know, most definitely we need to revisit the data to make sure that it gives us a level of guidance. However, you know, data and science will help guide us on that. So I know Ms. Lori also has her hand up. Laura, are you wanting to chime in as well?
Yes, I'm Lauren Duenas, and one of the things that have come up, if you look at the CDC guidelines, you have to look at the data for 2 whole weeks. It has to be consistently coming down. And right now, that's not what's showing. The data is just day by day. And one day it goes down and then the next day it goes back up. As soon as it goes up, we have to restart the count. So that's what we're going to be looking at in the next couple of weeks.
And Lori, you mentioned that as soon as it goes up, then you restart the count again. But you said that you mentioned 2 weeks. So if we can stay within that level for 2 weeks, then we're looking at the possibility of lifting some restrictions up. Is that the golden number?
That's what they look at. And we did that also with dengue. I mean, if you look at any of the communicable diseases, you take a look and see how consistently you stay on that level.
Okay. Thank you. Thank you, Madam Chair. That was all I had for this round. Thank you.
right, Senator Moylan? Oh, Senator Teichke, by the way, this is our final round, so anything else you've got, yeah, this is the time. Senator Moylan.
Thank you, Madam Chair. Let's see, for the new testing that we got going, is that really similar to what Jerry Perez was recommending from GVB, or is this different?
Same test.
Same test. Okay. Okay. Then the last question is, so regarding the CAR score, the goal is strive for 5. So if I understand based on the last statement, if we're able to keep that 5 or below, then we can look at, for 2 continuous weeks, then we can look at reducing the requirements or the restrictions. But if not, I suppose what we're also saying is that we're going to continue this, continuing the COVID-19 situation with the executive orders until we really come down below CAR score of 5 for 2 consecutive weeks. So if we're looking good and then on the 7th day we're looking really bad, it's just going to go another 30 days, another 30 days, another 30 days. So at least based on CDC guidelines today, or do we have to go by that and we can just determine that by ourselves without using that CDC guidelines? I'm just saying it sounds like we're going to be at this peak core forever until you see 2 consecutive weeks of a good CAR score. Am I understanding that correctly?
That or the vaccine. And so we're going to take a look and see which one, comes up. I think this is a message that will go out to the community, that if we keep consistently, wearing our masks, distancing, all of the things that we keep saying, we should see it come down. The biggest problem that I was looking at with CDC and the data from the other states is as soon as they see it come down a little bit, they all go, they lapse. And that's what creates the problems.
Thank you. Thank you, Madam Chair.
Thank you. Senator Teichke, any other questions? Senator Shelton, any questions? All right. Again, I want to thank you. Well, you know what I'm looking for? My own metric. This is just me. I'm looking for public health to be able within, for 2 weeks straight, to be able to keep up with any surge, with any amount of testing that we do, to keep up with the tracing on it. And so now that we've got this increased testing capacity, I really want to help you to do everything we can to make sure our tracing can handle it, because even with vaccines, I don't expect everybody will jump on the vaccine right away. And so it will help our community, but we'll still have COVID. And I think everything tells us to just learn to live with it. And we want to open businesses. We want to live with it. We want to open our schools, but we need isolation and tracing that is rapid in every instance. So I want to see that, and I want to see that for 2 weeks, despite any surges up and down, that we've got this kind of, elastic capacity. And I really think that would help us when we open up for travelers. It's going to help us, in the long run. And I know you know this. So let me help you, let us help you in any other way that you've thought of and just not been able to implement. Otherwise, I want to commend you for your also, being very adaptable and changing with the information that you get. And I'm very much looking forward to more information. And I hope that it helps the community. I hope that they also will be able to, we're all trying to work to convince everybody, each other, of our continued need to do this, our continued, what's effective. I want to be convinced that these masks are effective by, you guys, if you can, honing in even more as to what's causing spread in certain establishments versus others, so just so we can move forward confidently. And I always think of the schools as my ultimate goal, because if we know what will work, we can open schools, right? And I think we want that. We want to open tourism, but I want to open schools. I want the businesses to open. safely. So we're all depending on all of you. You each have your roles. It's been very clear. I love these hearings because it shows your expertise and your different roles in this regard. So I just want to thank you all. I can't thank you enough for all the work that you've done, all the different employees of public health that are working overtime to get all of this work done. So thank you. Is any of the deputy directors wanted to add anything to the end? Otherwise.
I just want to say that we talk about elastic capacity, and I do know that public health has moved and shifted and expanded and works either with community testing or targeted testing or the rapid engagement team, and we move accordingly. We offer the quarantine facility, unlike a lot of states that don't have one. Of course, we maintain our isolation facility, which many states actually do. But as much as we can move and shape with this elastic capacity, we continue to look to the community of Guam purely to be practicing these basic skills, these basic hand sanitizing and mask wearing and social distancing. As elementary as they seem, and as much as perhaps the community is tired of hearing them, they make a huge difference, and they make our job possible to not let people down by this being a partnership and not just depending upon a department to solve a problem. This is a community problem. It needs a community response. So I'm really looking out to the good people of Guam and even our visitors and so forth that are coming in, that make a difference, that live here, that breathe the air on our island, to stand up to the table and make sure that we all have a level of investment with this and a level of responsibility. But it's our pleasure to work through this pandemic and for positive outcomes. And we're delighted to be part of the team, and we take that responsibility. We will run with it. We just really want to make sure that it is a community partnership. So thank you for this opportunity to respond, and thank you for this hearing so we can communicate and educate our community of Guam a lot more. So thank you.
Thank you all again. So yeah, in closing, we've been pushing, and you have responded, and very much in these areas of determining funding and more staff for contact tracing especially, and of course other capacities, funding and staff for the Division of Environmental Health, who is in charge of monitoring and ensuring compliance so we can all open the businesses safely. More robust and timely data, so data-driven decisions are made and transparent. And I want to use that to convince the community. Yeah, it's working. We know this because we see the data, and very important for me, and and I think for many others in the community. Additional monitoring and care for positive cases, especially knowing our high risk community. We know this now. We have no reason not to pay more attention to those cases, and to prevent their deaths is really what the goal is. And of course, timely contact of those who have been in contact with positive cases, so we can prevent the spread, and so we can, I think everybody's trying to do that, and yeah, it's us helping to get them the tools, to give them all the tools. So I agree. The community is a huge part of this. Let's help them get all the tools they need, get the information they want, even though they might not need it, but they want it. And so let's get it to them, and let's help convince them to help us all. We'll all work together. And I want to thank all of you again. The time now is 4:14 p.m. And so this oversight hearing is hereby concluded. To all of you.
Thank you.
Thank
you, everyone. Bye.
Bye. Thank you. Good job, you.